everybody. Thanks for joining. We're just going to give folks maybe another minute to join, and then we'll go ahead and get started. Great. Well, we'll go ahead and get started so we can jump right in. I know our panelists have a lot of great thoughts and information for us tonight, and so hopefully we'll just continue to let people in as they arrive. Thank you all so much for joining this evening. Harvard Alumni for Mental Health is excited to have two panelists this evening to share their thoughts on advocacy in action and how people with lived experience of mental health issues and their allies can promote destigmatization, access to services, and community integration for all persons. I'm very excited to welcome Charles Hollins of Bay Cove Human Services and Jennifer Honig of the Massachusetts Association for Mental Health. I want to share just a little bit about our panelists, and then I'll turn it over to them. So Charles, as I said, joins us from Bay Cove. He's worked in the nonprofit and human services sector for 38 years. And he must have started when he was 10 in a variety of supervisory and executive positions. The populations that Charles has worked with includes adults, families, seniors living with mental illness, co-occurring developmental disabilities, addiction disorders, and homelessness. Charles has experience with community-based group homes, clubhouse model vocational and education day services, addiction and recovery treatment programs, jail diversion and pre-release community integration services. And for the past 14 years, Charles has served in Bay Cove's central administration as the Massachusetts licensed lobbyist responsible for the organization's government and community relations. So thanks for joining us, Charles. Jennifer is the co-director of public policy and government relations at the Massachusetts Association for Mental Health. She works in collaboration with a range of stakeholders on executive, judicial, and legislative branch initiatives. She has decades of experience leading legal advocacy on behalf of individuals with mental health issues who seek access to services and protection of fundamental rights. She has expertise in the areas of mental health care, education, rights in incarcerated facilities, the right to accept or refuse treatment, and disability discrimination. In pursuit of change, she's engaged in individual and systemic advocacy, institutional reform litigation, training, writing, and mentoring. I'm just so excited to be here with both of you this evening. And I think to start out, I certainly walked through your very impressive professional bios, but I'd love to hear from each of you a little bit more about what really drove you to this work. And so maybe Jennifer, if we want to start with you, and you can tell us a little bit about what brought you to this work.
Thank you. So I went to law school, and I went straight from college to law school, so I didn't have any work experience. And when I graduated, I went and asked, actually it was the head of city year, who was a friend of a friend, for some advice, and he said, go work with some clients. And it didn't seem very appealing to me for some reason, but I took his advice, and it turned out to be very good advice. And I represented clients who were being kicked out of methadone treatment programs, which, if you know about methadone treatment, to be kicked off cold turkey is a really terrible experience. And these are people that had maybe had a fight in a parking lot, or hadn't followed their treatment plan correctly or something. And it was just, so awful for them, because suddenly they were just being terminated from their programs. And these programs were regulated, and the process for kicking people out was regulated by the Department of Public Health in Massachusetts. But the hearing process was conducted within the programs. So I was sent into these programs that really had not very much information about how they were supposed to operate these hearings, and to try to convince them not to kick my clients out. And sort of that experience about realizing how important it is to make sure that public agencies or agencies that are regulated by the public follow the rules, the due process rules that they're supposed to follow, and provide services in a fair way, really was compelling. And it sort of replicated itself in all the work I did subsequently at Mental Health Legal Advisors Committee, which was a state agency that advocated for people with mental health issues, and now at Mass Association for Mental Health. And no matter what the setting was, whether it was kids in school who were being disciplined, or prisoners who were trying to access services, or people in inpatient mental health settings, people just wanted to understand what the process was, to be treated fairly, and to have their voice heard. And it's remarkable in so many settings that people's voices weren't even, not that they were listened to and not heard, but they were just not even listened to. In one example, when I first started at Mental Health Legal Advisors, I went to a lot of treatment team meetings, which were the meetings where all the professionals gather to talk about the client and how they're doing that week. And most of the time, they didn't ever include the patient. And if they did include the patient, it would only be at the end of the meeting after they decided everything. So that's sort of what's driven me, I think, all along.
Yeah, thank you so much for sharing that. And Charles, how about you?
So my start in human services was when I was a teenager. So I'm from a family of 8 siblings, and mom and dad, big household. We grew up in a family that was, according to income levels, was poor. And we had some traditional values around family, community, and faith and relationships. Those were priorities. I was at a church service. I was a teenager. A gentleman entered. His name is Darnell, and he was dressed in all black. He had a minister collar on, and he was disheveled. His hair hadn't been groomed probably months, maybe even years. He had a very foul odor, and he believed that he was Jesus Christ. And at a portion of the church service, he stood up and he said, "Thank you to everybody for worshiping him." Everybody looked on him with this expression of blasphemy, blasphemy. Of course, I didn't understand the whole church dynamic anyway at the time, but the deacons came and said, "You can't say that." He took his shirt out of his pants to show them where he was pierced in the side when he was on the cross. And at that point, the deacons escorted him out. I stood up and I was disturbed. And I said to everyone there, and I'm quivering even now because I quivered then, and said, "Isn't this the place for the brokenhearted?" And at that point, I left, followed the gentleman out. And by the way, sidebar, it was the blizzard of 1978 here in Massachusetts. So we were just sort of really pummeled by snow. I thought I was helping him by giving him my clothes, and I was missing the mark. He had a major mental illness, substance abuse. He was abused. He was homeless. I had no understanding. And I changed my college track at that point from broadcasting to human services. And then the course of my career went, and about 3 separate times, I didn't see him for 2 or 3 or 5 or 8 years. He'll pop up in a new facility that I'm working at, which was sort of to anchor that I made the right decision. And there was a convergence of several life factors, academic factors, that got me really cemented into the field. But that was my first kick.
Thank you so much for sharing that. So Jen, how have you seen advocacy change over the years?
Sure. It makes me laugh because when I first started 30 years ago, I remember people on the phone would say, "You sound so young, you sound like a kid." And they didn't feel like they could take me seriously. And I guess no one says that anymore. So, but I think the movement has totally evolved in a wonderful way. When I first started, I was lucky enough to meet Judy Chamberlain, who was one of the founders of the mental patients, well, it was called the Mental Patients Liberation Front in Cambridge, but it was modeled after a similar program in New York. She was involved in that in 1971. I didn't meet her till later, but this was a movement of mental health consumers or ex-patients or survivors. And they were focused on traditional mental health issues like restraint, civil commitment, rights in institutions, forced medication. And she and other people in Massachusetts were really powerful advocates, just amazing advocates. But for a long time, the movement was they were sort of outsiders, effective, but still outsiders. Gradually, I think over time, the people with lived experience have become part of the inside. There's certified peers working in all different agencies. They're working in prisons, they're working in state hospitals, they're working in community settings. So that's amazing. It gives new power. It doesn't mean necessarily that their voices are heard strongly enough, but it's a really big shift. And then I'd also say for legal advocates, even when I started, had already had some pretty big successes deinstitutionalizing Northampton State Hospital, doing some lawsuits, seminal cases around the substituted judgment process in Massachusetts, which allows for the forced treatment of people deemed incapable of making decisions about medication. But gradually over time, I think that movement has broadened and looked at other issues. It's the same way as the peer movement has to looking at rights of prisoners, rights in educational settings, rights with respect to housing. And today, rights with respect to the parole process, things that you might not have traditionally thought of as part of the mental health arena, but particularly with the Olmstead case, which is a Supreme Court case interpreting the Americans with Disabilities Act, which said that people have a right to treatment in the least segregated setting possible, otherwise it was discrimination. That has led advocates to look to see where people with disabilities are segregated. So they might be segregated in a workshop. That it used to be when I would go to Medfield, there'd be a workshop in the facility. Well, the facility itself is segregated, but then there's a workshop, so people are just not really working in the community. So workshops are segregated, but something like all different kinds of settings could be segregated. The parole process could not meet the standard that is set out in the EDA. So I think there's been a shift to just broaden all the areas that people can do advocacy, which is great.
That's terrific to hear. Charles, any things that you would want to add?
Not much, but I would just say one of the changes that happened for me over the several years and my colleagues is that the state Commonwealth has found a way to take advocacy small a, meaning that providers are talking to elected officials about the needs of the populations we serve, and we are helping people and educating individuals who are policymakers to make better decisions. We did that small a. The state decided to make it the big A, which means that now you are a 501c3, and if you are advocating, but you are doing it in a certain volume, and you have somebody who's specifically assigned to do it, that's called lobbying. You're trying to affect public policy, public opinion, legislative opinion, and that's a strategic lobbying. So if you meet a certain amount of hours and dollars spent on a person who actually goes to municipal, and state and federal level legislators, that you needed, elected officials, you needed to register. So that was a big change. So we're all registered lobbyists now, forced by the rules in the Commonwealth of Massachusetts. So be aware that there may be a time in your state where it's considered more than just advocacy, it's considered lobbying. The other thing that has changed is consortiums of specific disciplines like mental health, substance abuse, developmental disabilities, early intervention, operated in silos more, and they advocated for their own causes. They are now having consortium partnerships much more often, where we're pooling our voices together around common issues. Let's say workforce development, staff salaries, tuition reimbursement or forgiveness. So now we're pooling our voices together and uniting in a way where our voice is a lot more powerful and less likely to be ignored. And then last, where Jennifer was talking about the peer advocacy movement, that's probably by far the most effective tool in advancing our issues along the continuum from petition to policy to funding to culture.
Great. And what do you, while we're talking, Charles, what do you see as some of the biggest opportunities currently?
Well, one of the opportunities is the fact that we have so many media outlets. So we're much more publicized in terms of the news media portals, highlighting sort of the enormous societal divides in housing, employment, education, systemic racial and ethnic exclusion, poverty, and misinformation about mental illness, addiction disorders. So we find our advocacy arguments a lot more understood by more people because it's more out there. That's one. The people are more open-minded to hear different perspectives and understanding mental illness and developmental disabilities and homelessness as a result, and about addictions than they have been in, say, decades that I've worked in the field, again, because of the plethora of information out there. The program models that we're creating now create opportunities because our models are leaning more towards low threshold services where we can meet people where they are. There's not so much in terms of the intake process that screens so many people out, because we're realizing that we're dealing with people with comorbidities, and it's kind of difficult to kind of pigeonhole individuals into, well, you need substance abuse. No, you need mental health. So that argument is being lessened by these low threshold program models that are taking you where you are, dealing with the immediate needs, housing, food, stabilization, safety, and then developing relationships with that individual towards exploring more effective tools that will help the person be self-sufficient and independent.
Those are great. Thank you. Jen, what do you see as some of the barriers to accessing services?
So I just want to first echo what Charles was saying about the opportunities around, because just to add to that, the with people recognizing, I think they're recognizing the connection between their own situations, the mental health of their children, their struggles to get services, and the flaws in the system. I think that people see waits in emergency departments, waits trying to get a clinician, and they can connect that back to the workforce problems. And then when there's, and this goes to barriers, these are the barriers. So some of the solutions are these easing the access people have to services. And one area where I think that's going to be where the barriers can be really addressed is through the introduction of 988, which is a new, it's technically a new phone number, a way to access services across the country, but it's also going to be it's a crisis hotline so that people who don't know where to go or just are in crisis can call one number, receive counseling, maybe avoid going to an emergency department, avoid dealing with the police, but then have access to services. So it's both, it's the barriers are that we don't fully have that implemented yet, starting in July. It's going to be expensive to fund all the parts of it, although some parts of it are already funded by insurance. But to connect all that is going to be an issue. I think, we've talked about the barrier of the workforce problem. There's both not enough people working, there's low salaries, so people don't stay in their jobs, there's turnover, and that's difficult for patients. There's also not enough culturally and linguistically appropriate workers for different populations. So that's one issue. I think stigma remains, even though there is a greater acceptance of mental health issues, there's still stigma, particularly in some communities. There might be, or just barriers in going to this, not wanting to go to services, people not having the time off from work to get services. Telehealth has addressed some of that, but there's still some people for whom telehealth isn't something they want, or it doesn't work. There's the need for a broader range of treatments too. There's traditional medication and therapy, but people may want alternatives to that, and a recognition. I think there should be greater recognition that those alternatives are effective. Something as simple as exercise or pet therapy or whatever. So we need to think about a broad array of services for people.
That makes sense. Charles, anything you would add to the barriers that you've seen?
Yeah, I would definitely echo everything that Jennifer said, and I would just add the need continues to exceed the resources. This is what my experience is out in the front lines, and even with the aftermath of the pandemic, it's forcing an already strained amount of resources and already limited resources to close doors in a lot of programs because, as Jennifer talked about, the workforce shortage we have. That's a crisis. We're at a critical point. We're either closing services or reducing the services in order to manage risk in having adequate staff there. It's incredible. I don't know how many have heard about are from Massachusetts and know about our Mass and Cass or Melania Cass Boulevard and also Massachusetts Avenue, where it converges, where we have a lot of encampments happening there. We're finding that one of the barriers to services is that there is an increased need that is so complex with the comorbidities that the provider community that, again, experiencing a lessening of their staff workforce are overwhelmed. And the public display of drug use, the violence, the assaults, the sexual trafficking, and all of those incidents that are happening within those clusters of congregate encampments is creating a barrier for not only the people who need services, but also for the workforce that's trying to provide those services. They're becoming less apt to take the employment, to take these jobs because they are so difficult. So yes, there are a number of barriers that are converging there.
What have you seen? So I guess continuing with the Mass and Cass example, have you seen any, I guess, options or programs or things cropping up that have been successful? Maybe too early to tell.
Well, we have. We actually, Big Hope in particular, opened up a low threshold program called Marisol. And this particular program, Marisol means sunflower. So this particular program is one of the low threshold options for people who are in the Mass and Cass area, specifically working with the city of Boston to address this. Other providers are doing the same. And even with that, these programs, like Jennifer mentioned earlier, these programs are not being fully occupied. They're not at capacity. The need is great, but connecting people to the need is another challenge altogether. The mayor of the city of Boston came up with an intervention to get the encampments lessened in clustered areas throughout Boston, where the outcry was loud about how this is impacting businesses, impacting safety for people who are just traversing the area. So now there's the erection of these pods. These pods are like small, very upgraded encampments as far as I'm concerned. So they're heated, they have air conditioning, they have a bathroom, and then there's maybe if you have a cluster of like 10 single pods and another 10 with double pods with people who are couples, you'll have a 24-hour nurse available so that if there's an overdose, they're ready to administer Narcan. There's security officers there for safety to try to minimize drug trafficking or people being exploited. But these models have been used in other parts of the country, but we're still studying whether or not this is an effective transitional model to get people to accept more permanent services. So yeah, there's been some progress. There've been some efforts tried, but I think most of it's still considered pilot.
Okay. And you talked a bit about the legislature, the executive branch, law enforcement, security providers, community organizations. I guess, how do you see all these different groups fitting together or not in helping with access to mental health services?
I think closing the gap in education is the first one. So I think all like key stakeholders should first consider themselves organizations that listen and learns. That means inviting people who are with lived experience to talk and share their stories with their staff. Attitudes and perceptions not only speaks to the person's or organization's reality, but it also represents the fundamental premise, right, upon which we will take action or not take action. And so by listening and learning from individuals who are most impacted, we are no longer designating ourselves as rescuers, but we're partners with individuals towards change, and that will help a lot. Key stakeholders, again, we must extend our partnerships. Law enforcement and human service providers who have tried a number of times to use joint efforts to meet the need of a person arrested and who might also have a mental illness, who may have substance abuse, and have maybe a social worker ride along. We have a number of efforts that make sense, but the partnership needs to be strengthened. It needs to be something that's actually done in real time and not on paper. There's a lot on paper that I see and I talk with law enforcement agencies about that doesn't happen as much in communities. More law enforcement initiatives around community services, like community service officers whose job it is to either ride their bicycles, to walk the beat, to meet people where they are, to have relationships that are not related to exercising force, or enforcing the law, but just to get to kind of know people by name and face, have proven to be ineffective in neighborhoods. But now we have such a shortage of law enforcement officers in communities for the same reason why we have vacancies in our organizations. There's just this culture right now where it's difficult to retain and recruit staff in almost across industries. If governmental branches were working more with human service providers, when their constituents call for constituent services, they will have linkages and relationships with providers that can actually fit that particular need that's presented. So that's something that I try to do all the time when I go to the municipal or state elected officials' offices. One of the first things I say is kind of like a comical thing I say to them. I say, I want you to know that I'm your adjunct staff. I work for you. Whenever you have a need that fits under our umbrella of services, from child education or, from child developmental disabilities to our senior programs and all in between, you can have a place to start. And if we don't have the services here, we have partners in the industry who may have the services you need. So just kind of connecting that way helps to forge stronger relationships for accessibility.
Makes sense. It's very complex. It's a complex ecosystem for sure. Jen, is there anything that you would add as you think about all the different groups that go into people's experiences around mental health services?
Sure. It's what's so interesting about Massachusetts is that at the same time we're having this workforce shortage, we also have a lot of money coming in and a lot of good ideas coming in. So there's our American Rescue Plan Act funding, hundreds of millions of dollars. There was coming in one distribution last December. There's been huge amounts devoted to community-based mental health services, to workforce like loan forgiveness and workforce development, to some money for housing. So there is money coming in. They're just sometimes it's that the agencies need to ramp up to even be able to spend the money. So there's that, and then on the other side there's an executive. We have a governor who is well aware of healthcare issues and has been putting out, has his own new healthcare bill, has a budget that has a lot of money for all sorts of initiatives in it. So, and we have a legislature that has leadership who have had their own mental health issues or have mental health issues in their families, and really care about doing something good. We have the Senate mental health omnibus bill. We're hoping to have a House omnibus bill shortly that would complement it. So if some of these things get passed, I mean, we really have the opportunity to do something. But a part of the problem is that the workforce issue is sort of central, and you can't just instantly solve it because people have to come up through the system. So even if we have money for things, you still need the workers. So for example, we're getting there's low threshold housing at Massachusetts. There's also low threshold housing money in the current budget, in the supplemental budgets that are coming out now, and in the budget for next year for they're called safe havens, which is another low threshold kind of housing, for vouchers for DMH clients, which will allow them to have to rent apartments in the community. So there's money for that. We need people to help clients find the housing and to staff the houses.
Right, absolutely. I guess on a more positive note, what are some successful efforts that you've seen, Jen, for through advocacy?
Sure. I don't know if it's so positive. My example of positive success is actually sort of negative, but I think it's illustrative.
Well,
anyway.
it maybe highlights continued opportunity.
Yeah. So in Massachusetts, we have a prison system which includes a psychiatric hospital. It's one of like 2 states in the country where prisoners with serious mental health issues are treated in a prison facility rather than in a state mental health agency hospital. But that hospital, which is called Bridgewater, has come under scrutiny over many years. It was the subject of a really famous documentary many years ago. But in recent years, we advocates were successful in changing the culture of the facility and the practices. So we were successful in having the correction officers removed from the units and put on the periphery so that the units would be more therapeutic and more like a hospital. Also, the use of seclusion was drastically reduced. So seclusion was being used, which is sort of isolating people who are having sort of emergency situations, but it was being used day in and day out for some people, really, and not consistent with the statute. So that was a great success. Unfortunately, a report just came out from the Protection and Advocacy Agency for Massachusetts, which protects people with disabilities, cross disability, but particularly in this case, mental health. They've embedded a staff person in Bridgewater for the last few years, and they noticed 2 things. One was mold, which should be in an old facility, it's hard to deal with. But secondly, that they weren't using seclusion so much, but they were using this a forced emergency medication, which is a sort of odd thing in Massachusetts, where you can, if someone is deteriorating rapidly, you can forcibly medicate them, usually just like one time. But they're using it sort of on an ongoing basis on multiple people, and that really begs the question of what's the problem that's causing them to use it. Usually if you're using it, you should be like, oh, something's wrong with that person's treatment. You need to meet with them and figure out how to avoid that situation. But obviously it's being used seemingly, it's seemingly being used as a replacement for seclusion to control the population. And so, it shows that there's a cycle, I think, of achievement for advocates, and then you stop paying attention a little bit and things sort of don't seem as good anymore. I think it's important to celebrate victories when they happen, but it doesn't mean you can sort of stop looking, because there's just, I don't know if it's particular to mental health care or just any kind of advocacy. It just seems to constantly sort of ebb and flow depending on how much attention you're giving to an issue.
Sure. No, it makes sense. Absolutely. Charles, any examples you would add of successful advocacy efforts?
Yeah, one on the government relations and one on to the community relations. The government relations, when decades of level funded contracts is the experience of a lot of providers. It was happening for at least 25 years that I worked before we started looking at this piece of legislation called Chapter 257, which is designed to ensure that human service providers get fair and adequate rates. It gave us a mechanism where we could negotiate around what cost of living increases contracts should have, rather than being level funded for decades, which was a real difficult challenge for us in retaining staff. The other one we've been fighting for is also a living wage. And with comparable jobs that are done in human services, if you just stepped over to healthcare and did pretty much the exact same job, you will automatically get somewhere as like $10,000 more in your salary in a year. And if we are going to try to recruit and retain staff at our organizations, when you can take commensurate skills and just walk over to the healthcare industry, it became a real difficulty for us. So working on a living wage together and making progress along that has also been an example of sort of a lot of successful advocacy. On a more community-based level, I'll give you an anecdotal story that we were opening up 2 group homes for developmentally disabled adults, seniors, who for the most part were nonverbal and non-ambulatory. And the community association in that area that we had to meet with through the community process said, no, we do not want you here. This is an example of the pushback that communities give sometimes programs because of misinformation out there. So these individuals couldn't be less harmless than they were, but they were described as drug addicts, criminals. There was a petition that went around, a flyer that described these elderly, developmentally disabled, in a wheelchair individuals as criminals. It was a very difficult time. This community group was very powerful and very connected. The elected officials just said whatever they said. So they said they didn't want us there. The elected officials like, the community doesn't want you there. It's gonna compromise their property values, etc. We had a as of right project. So even in the zoning board, we were able to go forward with we believed in what we did. We educated the community as much as we could. And we decided that the individuals who are living with these disabilities deserve housing in their communities, and we're not going to turn away. We moved in, and one of the things I did was I listened and educated the individuals there, met privately with elected officials. I joined the neighborhood association that was forcing us to hear some very difficult pushback. I actually became a part of community efforts that were addressing feral cats and street safety, street lights. We were paying our dues like everyone else. After about 2 years, they noticed that we were among the best neighbors. We were facing a crisis where our plumbing was not adequate for the kind of pressure that needed to be in our sprinkler system. But it was the moratorium period. It was past November 15th and you can't dig in the ground. This same neighborhood association went to bat for us to the city, demanded, had petitions signed that they open the ground and get that piping changed for this program so that these individuals, these wonderful people who are our neighbors can be safe. And they were successful. And today, that same group is among our most powerful, strong supporters and advocates. So the education and advocacy process with educating even our community officials and neighbors that we are next to in our programs goes a long way in establishing access to care and understanding and changing the culture of neighborhoods. So there's a feel-good story.
Yeah, that is. Thank you. Well, one more question for me, and then I definitely hope, I'm sure the audience has some questions as well. We'll start with you, Charles. What do you think we can do, those of us on the call that maybe aren't professional lobbyists like yourself or involved in advocacy? What can we do in our own communities to help?
A couple of things. One is visit and volunteer at provider programs in your area to get a firsthand experience with the important work that's being done in your neighborhoods or in your area. That's one. That's a very powerful one. You may not have the ability to volunteer at all of the settings because of privacy rights, but there are some settings that you can. Be an active constituent with your elected official. Write a letter, make a phone call, visit the office anytime that you're impacted by a piece of legislation or public policy that just doesn't feel like it's protecting the health and welfare of the community, doesn't represent your values. This is simple. Vote for the person that most closely shares your priorities. And when it comes to connecting with your elected official, a visit, whether in person or virtual, is probably your first line of defense. That's your most effective piece. The second one is writing, actually writing a letter that they have to read, not sending an email, but literally writing a letter, going old school. Phone calls are great, conversations are great. Emails can come last, and then, of course, hold like education and awareness groups with your inner circle of friends. Invite individuals who have lived experiences or that does the kind of work that Jennifer and myself, that we do and people in your area does. Invite them to share their experiences, share the work that they do, answer questions around what's going on in the community and how you can be helpful. To tell you the story, sponsor a friend raiser for a human service program in your area, and invite that human service program to tell you about their great work and brag about what they do and what their challenges are. Do this with personal friends, a friend raiser. Do it with, if you're in a faith-based organization or some other Rotary club, do it with that group. Workplace that are doing workshops at your place of employment. Invite a human service provider who is really on the front lines to come in and talk to a group of staff about the work that they do and how you can get involved and how it affects changes in your community. Use the hell out of your social media tools, right? So as you're getting resources, as you're learning about tips and tools, just spread the word. The more we do that, the more the wealth of information is out there, the more creative we can get about that, the more we affect public opinion. And so those are a couple of the things that I would kind of throw out there.
Yeah, those are great. Jen, any that you'd want to add before we open it up for further questions?
Sure. I was thinking along the slightly different lines, that just looking around your community to see what kind of services your community offers people. You may think from your perspective that your community has everything it needs. It has a police station and a little town hall and a library or whatever. But if you look at it from a lens maybe of someone who needs more support, does your community have that service? Charles was talking about Mass and Cass and putting pods in a certain neighborhood, but all of our communities should serve the whole range of populations. Is there a place for people with substance use disorders to receive treatment in your community? Or, those places have trouble being located because nobody wants them either. Is there a group home for young people in your community? Are there services for elders, like elder mental health outreach teams? Is there an urgent care center for behavioral health needs? I think more and more we're going to start to see that kind of service pop up. Is there a crisis center in the community that also is going to pop up? Is there low-income housing? And are you supporting low-income housing in your community? Does your community have enough low-income housing for its population? What's the police department doing? Does it have co-responder teams that Charles was talking about? Is it trained on mental health issues? Is it speaking about mental health challenges and how to approach people? Are there peer respite programs? There could be. They're popping up. They're called living rooms or There's recovery learning communities. Living rooms are like kind of respite programs that people can go to instead of going to a hospital. Are there amenities for kids, for teens? Do schools have mental health services? Are there nurses? Are there curriculum appropriate for teenagers? Are we adequately funding special ed? I mean, it's a burden on towns because it's coming out of the town budget, but are we adequately funding special ed in our communities? Are we looking at the rates of depression among different populations and having services that support those people? And my favorite one, are we planting trees? Do we have an environment that's supportive, because your environment can make a huge difference. So there's a group in Boston now working on tree equity. So check that out too.
That's a great one. All right, well, thank you. Well, we did send out a poll, so if it's just 2 questions, if you have a moment, answer that. And we still have 15 minutes, and would love to just open it up for folks from the audience with questions. Feel free to unmute yourself and ask questions, or if you prefer to put them in the chat, that's fine as well.
I know that sometimes we take the time to think about it and to reflect before questions bubble up. So I'm also going to volunteer if people want to private message me and feel a little shy about asking their questions. You can click in the chat to whom you're sending. And if you find my name, feel free. I will relay your question anonymously.
Mohammed, it looks like you have your hand up.
Yes, thank you, Anne. Well, really appreciate very dense discussion, Charles and Jennifer. It's been really insightful in terms of what you were putting forward for strategies towards the coalitions for making advocacy plans for mental health, care provision, and preventive measures, or preventive medicine, if you like, in terms of mental health. And that's really crucial. I'm a medical and clinical neuroscientist and cognitivist. I'm based in Shiraz, Iran, and I've been working in the field of mental health care for the past 10, 15 humble years of experience. And then I came across the idea that it would be worthwhile if we're just cross-linking all the things that you were indicating with regards to the legislation and the policy making to the SDGs from the United Nations, because we have 17 sustainable development goals that they are in line with all the different perspectives and pillars that you were highlighting, ranging from the environmental health and also affective health, mental health, and general well-being. Specifically for the SDG 3 of the United Nations, that is very particularly highlighting the importance of mental health and well-being. And something is for certain that bridging these ideas to the whole concept of the sustainability and the sustainable goals of the UN is going to be worthwhile. And I know that in the United States, there's also been some recent moves towards this. So maybe we can think about that. And as I was going through the page of the Massachusetts Association for Mental Health, I realized that promoting wellness is amongst one of the key, fundamental issues that you are tapping into. So providing the platform for the free access to mental health care without stigmatization and without criminalization of mental health care is something that's really matters, and we need to really have open eyes towards it, not only for the older populations or the people who are actually currently suffering from a wide range of mental health predicaments, including substance use disorders or mental illnesses, access 1 disorder, if you like, and also access 2, which refers to affective dysregulation or personality disorder, which is quite wide. And they are not, separate ideas. They are not segregated. It's a whole intricated and also interdigitated concept that we need to take it as a whole. So what I would like to highlight here, to cut the long story short, is that when we're talking about the mental health, it is not necessarily one word. it is impregnated with some other concepts, including behavioral health, affective health, brain health, and not only that, but also we need to go for the cost utility analysis of the practices that we are involved with, the insurance policy, the barriers that we have had. So what if people would get their mental health checked like they have their annual wellness visits in the US that you have within the Medicare? And we've had, as people go for the prostate cancer screening, the people go for breast cancer screening, why don't we think of providing them with the facility or the opportunity to go for neuroscreen or brain health check screening? We've already published a paper in the World Society for Brain Mapping and Therapeutics, SBMT, in Los Angeles, California. And the title of the paper, if you search the term neuroscreen in PubMed, that will pop up, and that's already presented to the Biden administration for being considered as one of the possibilities for the health policy constitutions. That's all I wanted to highlight, and I just want to thank again for the very insightful and provocative ideas that you selflessly shared here. Appreciate it, and thank to the HOM for providing this platform. Appreciate it a lot. This is very good.
Great. Thanks so much for your comments there. Jen or Charles, anything that you would want to add?
Well, one of the things that came to mind as you were talking, Mohammed, and thank you for all of that information. And it's good to know what's happening across the world as well, that there is always a need for learning in an international partnership. I think this should be, there are formal forums there that are happening, but there's never too many, so that we can establish ways of exchanging information. So I really appreciate what you shared there. So I just wanted to ask you, and with the insurances, when you, I don't know if you said you presented a proposal around including sort of the mental health screening as a part of like annual exams, what response did you get back from, let's say, insurance providers for whom, like if you see your primary care provider, unless you present that you have concerns in a certain area, that's not going to be a part of routine screening. But it sounds like you were saying that we would be in a better position as sort of in the whole world, that if we're screening for physical health issues, that we screen for behavioral health issues, neural health issues, and we do all of this in order to catch something or identify something, that we can be more effective with an intervention early on, rather than waiting until it gets to a point where the person's life is out of control to some degree, and now we're trying to catch up and repair. What has been the feedback you've gotten around insurance policies, insurance providers?
Well, actually, that is underway. I mean, it's been recently published in a journal of Alzheimer's disease, and that all revolves around the idea of preventive medicine and predictive medicine. So there has been a very, succinct cost utility analysis. So if we go for prevention ahead of the time diagnosis, and if we're going to isolate the high-risk population and provide them preventive measures to stay away from the high-risk profile of the mental health disorders, how this is going to save the cost burden in the long run. This has been provided to the health summit and the policymakers within Mr. Biden's administration. So we're just waiting for their feedback, maybe within. But if you want to get more highlights about that, you may just reach out to SBMT or Brain Mapping Foundation. This has been linked to the Brain Project, Obama's Brain Project back in 2013. So this is something which is going to be really taken seriously, and we're just keeping the fingers crossed to see positive feedback.
All right. Okay. Can I have a question, Anne?
Of course.
Yeah. Thanks for the speakers, Charles and Jennifer. And also thanks for hosting this, Anne. My question is simple. What do you do for those people who are not able to have this health insurance, the marginalized people with either a drug addiction or elderly, disability. So how do you help them who have no health insurance for mental health? Both for Charles and Jennifer.
Massachusetts is lucky in that we have a mass health program, which is a Medicaid funded program that insures not the whole population, but much of the population. And just as an example, people coming out of Department of Youth Service, juvenile justice settings, kids sort of have that service. So when they come out, they can start accessing those services right away. There's efforts to make sure that's happening for prisoners too, even better, even more fluidly than it does now. So the idea would be that if people had drug issues, we'd enroll them in mass health as well. And in for many mental health services, the services provided by mass health are better than the services provided by the private providers. And actually there's legislation on a number of different kinds of services right now trying to get private providers to step up and provide the same level of care that mass health is providing. But obviously it's not every state is Massachusetts, and it's a huge barrier. And even aside from that, there's still parity issues where mental health services aren't insured to the same extent in some ways as physical health services. Even though we have had a series of state and federal parity laws, there's not always a parity in services, in the amount of services, the quality of services, or how you can access them. And in Massachusetts, the enforcement of parity laws has not been as robust as it should be. So there's legislation pending to try to improve that as well.
So what I would say also is that along with the mass health provision, the culture of services, like say, at least in Massachusetts, and I've talked to some other states that don't have the same culture of service, so there is a challenge, but we at least have the ability to serve people who other states probably can't or won't. And that's one of the reasons why a lot of people come to our state, is because of some of our services. I mean, we're talking about undocumented individuals. We're talking about people who are living in poverty, who are homeless. It's like there's a checkoff list for services that we have that if you fit a certain criteria of income, meaning that you're low income, you're in poverty, there's a plethora of services available for people, as Jennifer was talking about. So that's something that we need to duplicate though in other states. I feel good in Massachusetts about that. And that's one of the undercurrents for the whole low threshold housing and other services. It is all about making services more and more accessible to the people who need it most.
Thank you.
You're welcome.
Can I go back and just add a comment to the Mohammed's original?
Yeah.
I was just going to mention that there's also efforts in Massachusetts to link up primary care and behavioral health services. There's efforts to do that for youth, so that if youth go in for one kind of service, they can get referred over to behavioral health service without having to be billed as a separate service or pay for separately. There's models of co-location and ideas to do that in schools so that kids could get mental health services right in the schools, so they wouldn't have to go someplace else. The governor's healthcare bill that just came out has the idea of increasing spending on behavioral health and primary care by 30% over 3 years, because those two services together are underfunded, and there's some flexibility in how providers, these are large providers, would do that, and there's benchmarks to set, but the idea is to link those two kinds of services together.
That's great. Well, gosh, that brings us right to 9 o'clock, and so I want to thank Jennifer and Charles so much for joining us this evening. This was a very informative and engaging talk, and the chat was very active. There are some great links out there, so check the articles out that are there. And thank you so much for participating in the event, and hope to see everybody at future HOM events.
Thank you for having us.
Everybody.
And thank you very much for having us.
Absolutely. All right. Thank you.